Welcome to Books of Our Time, produced by the Massachusetts School of Law and seen nationwide. With me today is Dr. Jerome P. Cassirer to discuss his new book entitled On the Take: How Medicine's Complicity with Big Business Can Endanger Your Health. The book details how medicine in all its branches has become infused with a money-making or profit motive, instead of always putting the interests of the patient first. Dr. Cassirer is a distinguished professor of medicine at one of the country's great medical schools at Tufts University, and is an adjunct professor of medicine and bioethics at another of the country's great medical schools at Case Western Reserve University. He teaches 2 days a week at each school. And for approximately a decade, Dr. Cassirer was the editor of the highly prestigious New England Journal of Medicine. He is one of the country's leading commentators on the medical profession, and I am Lawrence R. Velvel, the Dean of the Massachusetts School of Law. Doctor, thank you very much for coming up to talk to us
Thank you for
today.
inviting me.
Yes, sir. Very valuable and important book that you have written. Doctor, in the last year, there's not only been your book, there has been a spate of books. There have been 5 books written by highly prestigious people on the problems in the medical profession. Yourself, your successor at the New England Journal, 2 Harvard professors, and a pair of Pulitzer Prize-winning reporters who have won 2 Pulitzer Prizes, not just 1. So with all these books coming out detailing problems in the medical profession, one gets the idea there must be a problem here. What is the problem?
Well, there is a problem, and the problem rests not only with industry itself, but also with the physicians that are engaged by industry in a variety of tasks.
By industry, you mean the pharmaceutical industry?
Well, I'm talking about not just the pharmaceutical industry, but the biomedical industry and also the device industry.
Okay.
And I guess the problem that concerned me the most was the effects of the enormous amount of money that these industries are pouring into the medical profession. It is really kind of astonishing when you think of the amount of money that industry pours into marketing efforts. When you're sitting in your living room watching television, I imagine most people assume that all the advertising is directed at them. You see, of course, people sitting in bathtubs, touching each other by the hand, and the advertisements for Cialis and Viagra and so forth. The fact is that if you look at the $20 billion, we're not talking about millions, we're talking about billions of dollars, that the industries spend on advertising. Almost 90% of that goes to advertising to doctors. Perhaps around $4 million goes to advertising to the lay public, but a large fraction of the advertising is directed at doctors. And it's not just advertising in medical journals, but a whole variety of ways that the industry tries to engage physicians in their marketing pursuits.
Doctor, we'll get into about 20 or more, actually, specific individual examples of that you discuss in your book. But before we do, give us a brief overview of some of the ways in which the pharmaceutical and device and other members of the industry are trying to reach, well, they are reaching the medical profession with their money.
Well, for one reason, for one mechanism, they engage physicians in continuing medical education. The pharmaceutical industry is now the major supporter of continuing education of physicians. So, for example, they will pay speakers. They will have a bureau of speakers that they pay to travel around the country to give talks. Just as an example, I was in New Haven at the most expensive restaurant in New Haven because I was there recruiting a physician to head the cardiology division at Yale when I was working at Yale. And I went into the back room and came across a physician from Harvard in New Haven at Yale who was giving a lecture to about
Yeah.
30 or 40
Yeah.
physicians
Yeah.
in the back room, the most expensive restaurant.
Yeah.
So it's one example of how the industry engages physicians in these kinds of postgraduate education pursuits. Another example is what they do in medical meetings. So if you go, for example, to a meeting of the National Kidney Foundation or the American Heart Association or one of those major meetings, you find that you can go free to a dinner meeting after the actual scientific program. You can go to a lecture in the evening or at lunchtime or at breakfast time with one of the speakers that are paid by the pharmaceutical industry. So continuing medical education is funded in a major way by industry. What's wrong with that, you might ask? Well, the answer is that we know from various reports, especially with respect to the recent revelations about Vioxx, that the speakers are being watched. Big Brother's out there watching the speakers to make sure that they're staying on point. They want to be sure that their message is a message that is favorable to the company. Now, what that means to us, what does it mean to a speaker? Well, a speaker knows, they must know that if they stay away from the straight and narrow, they're not going to be any longer on the Speakers Bureau.
Yeah.
So,
And big bucks are involved.
and big bucks are involved, exactly. That's just one example of many. And I didn't even mention the enormous number of gifts and meals that physicians get. I mean, for example, doctors in their private practice offices often invite the drug representatives, 88,000 of them, by the way, into their offices to bring lunches for their staff. And in exchange for that, they will spend a few minutes with the drug representative. Now, again, what's wrong with that? The answer is that what the drug representatives are going to recommend are the newest and the most expensive drugs. What does that do to the care? Well, the doctors are going to be using the most expensive drugs and will become used to using those drugs, and that, of course, raises the cost of care. And of course, there are drugs that are the newest. We don't always know what the side effects of those drugs
And
is.
they're not always the best, I gather.
They're not always the best.
And they do, as you say, have side effects. And even if they're equal to others, the others may do as much for the patient, far less expensively.
Yes.
So there's a lot of problems. All right, we'll get into, as I say, about 20 or 25 of those problems. But before we get into each one of them individually, and you've already covered a couple of them now, let's talk about what has gone on, what has happened in medicine in the last 50 years. You became a doctor about 50 years ago, not too much before I became a lawyer. And I think there's been more change in medicine than in law. Let's discuss some of the aspects of medicine, the way things were then, the way things are now. Let's start with, for example, the prestige accruing to doctors and the kinds of practices that doctors are engaged in or were engaged in.
Well, things have changed in medicine enormously. When I was in medical school, medicine was a kind of mom and pop operation. You had small practices. There was very little in the way of specialism. There were cardiologists and gastroenterologists, and a few others such as allergists. But there was not even any specialty of nephrology that I eventually became, as an example. And in academic medicine, it was also a kind of a low-key operation. There were, in a medical school, there may have been a few dozen people that were full-time in the academic centers, but most people were volunteers. At the same time, there was a lot of volunteerism in medicine. Doctors would take care of the sick, even when they had very little to pay them. Sometimes they paid them with chickens and geese. And at the same time, medicine was really quite primitive at the time. The number of drugs that we had available to us when I was an intern, now I actually laugh about it. And, and the kinds of diagnostic tests that we had available were some of them quite horrific. For example, to study the brain, or the spinal cord, it was often necessary to do a spinal tap and inject heavy substance into the spinal canal, and then do X-rays as that heavy substance moved along the canal or up into the brain. It was a terrible procedure. Now the differences are absolutely stunning.
Yeah.
We have CT scans, we have MRIs, we have PET scans, we have ultrasounds, and we have medications that, if you had told me 50 years ago that we would have the kind of medications we have today, I would have been skeptical.
Yeah, yeah. What about the prestige? You know, as we were saying before the show, I just went back to a fraternity reunion, and out of 60 people, something like 15 or 16 were doctors, which was a reflection of the prestige in which the profession was held in those days. And the rest of us, as I said, were people who couldn't get into medical school again. But is it similar today? Is it the same today?
I don't know if it's the same, but there still is an enormous prestige of going into medicine. And even though the numbers of people that are applying to medical schools have fallen over the years somewhat, there still is a large number of people that are applying to medical school. And I'm not sure that prestige is the only reason for it. I think in general people think that medicine provides a somewhat guaranteed income. Yeah. I can tell you that the guarantee is no longer as strong as it was in the past, but still, people who go into medicine will in general make a very good living.
Doctor, the other side of that, I gather from reading your book, is that money, the profit motive, has become a major factor in medicine, and one which gets in the way of the doctor-patient relationship.
Well, we have to understand that there is no incentive system that is neutral with respect to money. Doctors are, just think about the way doctors are paid. Yeah. They're paid either on a fee-for-service basis, which means they get a certain fee for every procedure they do, for every office visit, or they're paid on the basis of the population that they serve, a standard fee per patient per year, or they're full salary. Now, if you think about that, in each system, there's an incentive. In the fee-for-service system, there's an incentive to do more work, to do more procedures, to bill for more items, to see the patient more frequently. In the capitated system, where you get a fixed fee per patient per year, there's
an HMO or an insurance company.
Right. Yeah. There's an incentive to do less. Yeah. And the reason for that is that the more you do, the less money available for your salary toward the end of the year. And then in a system where you are full-time salaried, as I was for many years when I was on the full-time staff at the New England Medical Center here in Boston, there's an incentive not to work hard. Now, you know, most doctors are not incented in that way, but I mean, doctors work hard anyway. But nonetheless, no matter what, there's always some kind of financial inducement of any kind of payment system.
Yeah, and now the inducements, which we'll get into, have often involved really big bucks because of the money of what is called big pharma, the 8 or 10 large pharmaceutical and device companies and bio companies. How has the the role of research changed in medicine over the 50 years? And how has the role of what I will call the everyday family doctor changed in that research with regard to clinical trials?
Well, clinical trials are, for the most part, trials of drugs. And although the National Institutes of Health supports an enormous amount of research, they, in general, do not support a lot of research on drugs. So that leaves the research on drugs, the responsibility for the research on drugs, to the pharmaceutical companies. And I think properly it belongs there. Now, what the pharmaceutical companies do is they engage not only the family physicians or other physicians in practice, but also physicians in the academic medical centers to do the research for them. And at the academic medical centers, there tends to be a fair amount of control over the quality of the work, the design of the studies, and so forth. But at the same time, there's a lot of research now being done in the community by research organizations. And in those, the control may not be quite so specific. And the problem is that many of the physicians who are involved in that research in the community are not trained to do research. So they may not be as skilled at it. That's one point. But the second point that really should concern all of us is that physicians in the community are being paid, sometimes even bonuses, to enroll patients in the studies. And the worry that has actually happened from time to time is that physicians may enroll patients in these clinical trials when they are not really, when the patient may not really be eligible. And obviously there's an incentive there to enroll patients, especially if there's a bonus involved.
I was really struck by the fact that you pointed out that even a famous Princeton, I believe he's an economist, named Yuval Reinhardt, who writes on these matters all the time, felt what I would call social pressure when his doctor asked him to enroll in a clinical trial, and he did indeed enroll in a clinical trial, though he didn't want to. This is a guy who's quoted in the papers all the time, so it gives you some indication of what the kind of pressure that's involved.
Well, I know Uwe personally, and when I read that myself, I was kind of astonished myself that he was so passive about it. He's not a passive fellow, but it shows the point that these relationship between a doctor and a patient is a compelling one, and doctors don't like to disappoint patients don't like to disappoint their doctors. They don't like to say no to their doctors, and a doctor still has an enormous kind of presence and authority. And people want to believe their doctors. They want to trust them. And in general, I have to say, they're pretty trustworthy as a general rule.
Doctor, you say that there has, and of course no one I believe would disagree, that there has been phenomenal, and you mentioned it here, phenomenal progress in medicine in the last 50 years. Now, because of this progress, and maybe even 50 years ago, I don't know, the pharmaceutical companies and the medical establishment would say, and now there's a lot of conservative commentary that says we have the best medical system in the world, don't fool with it, and that high drug prices are the price we pay for having a research system that has brought us all of these miracle drugs and devices, and now bringing us biological methods of helping people, curing people. There are those, however, who take some exception to this, and I gather you're one of them. And there are lots of reasons for these exceptions, such as whether we are in the top 10 in medicine in the world, and whether we really do have to pay, whether research really is going on to the extent that's claimed, and so on. Why don't you discuss this entire question of, do we really have the best medical system in the world?
Well, I would start out by saying that if I or any member of my family were ill, I'd want to be taken care of in the United States. There are unequivocally absolutely outstanding academic medical centers and even many small hospitals that give absolutely first-class care. There's no question about that. On certain criteria, we don't do very well. In certain criteria such as infant mortality, we score lower than other countries, quite a lot lower. We also score in the other direction, overwhelmingly higher in terms of the amount of money we spend on medical care, and yet, from the standpoint of the overall population, we can't show that we are twice as good as anybody else. We spend
and our longevity is less than about 12 or 13 countries in the world.
Exactly.
Yeah.
So we spend $1.7 trillion on medical care, which represents about 15% of our gross domestic product. Yeah. That's an enormous amount of money. And the question that people have asked, are we really getting our money's worth? Most people believe we're not.
Yeah. Yeah, we're going to come back to this subject in just a moment. We have to take a break. Stay with us. We'll be right back with Dr. Jerome Cassirer and his book, On the Take.
They came from every corner of the country, from small towns and big cities. But they all shared one thing in common. They belonged to a family called Marines, a tough and determined few dedicated to protecting everything we hold sacred. And still, they come. Celebrate the 225-year history of those proud few who have earned the title Marine.
This is the story about a group of kids who volunteered.
Doing something nice for someone.
We fixed stuff.
Did some art projects with the kids.
We fixed up his house.
We worked in the woods.
Cleaned up the park.
Did something for the planet.
We just did it.
No other reason. And you know what? It was great.
At first, they didn't know each other.
Well, that didn't last long.
This guy is really funny.
Me? These are my new friends.
Are you into it?
Call 4-H or check out our website at areyouintoit.com.
Kids aren't afraid of other kids. Or people with different color skin. That's because kids know there are other things. Worse things. Bigger things to be afraid of. Like monsters from outer space! Remember, friends come in all colors.
Before you know it, she talks. Before you know it, she walks. Before you know it, she knows you. Before you know it, she has a heart. Before you know you're pregnant, when your baby's no bigger than a grain of rice. Before she's a twinkle in your eye, that's when you need to take folic acid every day. After that, it's too late to prevent some serious birth defects. Folic acid now, before you know it.
Welcome back. Doctor, some of the things that are said are that drug company profits are something like 18% on total revenues, and that the marketing expenditures are about 27%, and marketing and drug research is only 14 or 15%. Or I've even heard lower figures. You think this is accurate, that in fact the pharmaceutical companies are not spending the major share of their expenditures on research for drugs and devices?
Well, it's really quite controversial. The critics of industry have made comments similar to yours, saying that the drug companies are exaggerating the amount of money they spend on research and underplaying the amount of money they spend on marketing. The industry argues just the opposite, as you said, and that is that they need all that money to support their research. But in fact, you're right. They do pay very high salaries to their CEOs and other people at the higher levels, and they do pay substantial profits. Although I have to say, in recent weeks, the drug companies haven't been doing quite as well as they have in the past. I think that some of the criticisms of industry relate to the fact that the number of new important drugs that they have produced in the past 5 years has not been very impressive, that they produce a lot of Me Too drugs that are very similar to existing drugs and not much better, if any better at all.
Are the statins an example of that?
There are many different statins, and the evidence that one is better than the other is pretty marginal. And also that they prolong their patents in ways that are kind of inappropriate, rather than putting their money into the development of hot new products. I think if you look over a longer span of time, drug companies and biotech industry has produced some very important drugs. And it looks like they have some important drugs in the pipeline now.
Well, let's hope. Do you personally think that there is merit to the fact that apparently we pay 50% more for drugs in the United States than is paid in Canada, Great Britain, and Australia, which is, of course, the reason why people have been going up to Canada, and there's the drug company to get their drugs, and the drug companies are trying to stop this. But do you think that it's legitimate that we pay that much more than is paid in these other nations?
The argument is that the drugs that come from Canada are not as effective or not as trustworthy as the drugs that we use in the United States. That's pretty much a bogus argument. The drugs that are obtained from Canada are pretty much the same drugs as we get. Is it appropriate that we pay more for it? I think not. But that's how the market goes. As you know, there was a move to try to allow Medicare to be able to negotiate with the pharmaceutical companies on price, but Congress prevented that. And you have to ask yourself, why did Congress prevent something that would be useful to the American people? The answer is they were under the influence of the lobbyists for the companies that make the drugs.
Sure. And they get I presume they get major campaign contributions and that kind of thing, which the Supreme Court tells us is not bribery. Those are campaign contributions. If I took money, it would be bribery. But then nobody elected me to take money. Let's turn to this huge list of examples, some of which you have touched on, of the ways in which pharmaceutical companies are spreading the green around within the medical profession. You've already talked about the conferences and the advice. I understand that they also give free advice to doctors on how to run an office. Now, one wouldn't think that somebody needs advice on how to run an office, but it actually is much more complicated today than it was 50 years ago, isn't it?
Yes, it is. I think, over the years, there have been efforts to rein in on the pharmaceutical industry and their relation with doctors. And the American Medical Association has developed guidelines, and so has PhRMA, the organization that kind of speaks for the pharmaceutical industry. So they developed new guidelines which restrict the kinds of things that doctors will get from pharmaceutical companies. For example, doctors are not allowed to take their wives or their spouses to dinners where they have these educational ventures that I talked about before. So the fact is, this is like a big bubble, or like a big balloon. You push it in one side and it pops out another side. So the pharmaceutical companies have these huge budgets for marketing, and you can be sure that they're going to find ways of passing this money on to physicians in their marketing efforts to market their drugs.
Yeah.
And one of the industry is trying to influence doctors to buy their products.
Well, you know, the people I talk to who are doctors, and I don't know that many of them, but I do know some, point out that the amount of paperwork in offices because of HMOs and Medicare and Medicaid, you know, is just a fantastic thing now. I mean, you go in and you see 4 and 5 people sitting there, obviously doing some kind of accounting work or some kind of billing work. This is a lot different than it was in the 50s. So.
Oh, very different.
Yeah.
There's no question about it. Doctors are also inundated with paperwork, in part because we're talking about the doctor in practice, of course, because instead of having to deal with one insurance company, he may have to deal with 10, 12 more. He has to document everything much more carefully. The amount of time they have available to deal with each individual patient has been constricted. It's not only paperwork, but the complexities of practice have become much greater. And so doctors are under siege, and it's not as easy to practice medicine as it used to be.
You know, you point out that doctors claim, with some fair amount of indignation apparently, that me be corrupted because I got pens and pencils and some notebooks and things. It's not going to happen. You know, I believe in evidence-based medicine. Blah blah blah. What's your answer to the argument that doctors are not going to be corrupted by at least the small gifts that they receive on a regular basis?
Well, there's a lot of evidence in the medical literature that that physicians are influenced by meals and gifts and things like that. And when you think about it, the industry spends an enormous amount of money thinking about how to influence doctors. And it's hard to imagine that they would be spending $16 billion a year trying to influence doctors if they didn't think that they could be influenced.
16 billion.
Something like that, 16, 17, who knows? It could be more.
Yeah, we have enough faith in the capitalist system that we don't think they're throwing their money away.
I think that they think they're not throwing their money away.
Fair enough, fair enough. You talked about the fact that doctors are paid to make speeches at conferences and speeches at dinners and so on and so forth. The doctors who are attending sometimes get their way paid for to listen to the speech, don't they? And these are at fancy places.
That happens less often now than it has in the past, but it still happens. There's no question about that. Doctors are still somehow being paid to do that. They're paid to lecture at these places and so forth. There's a recent example that is not in the book, but I think is something that kind of exemplifies the problem of these financial conflicts as well as any other. It has to do with the recent FDA action on the COX-2 inhibitors. Would you like me to describe that?
Well, it's not in the book. We can't talk about it. No, I'm just kidding. Go ahead, doctor. Go ahead.
Well, I think it's a wonderful example of the kinds of problems that conflict of interest raise. So the FDA called a meeting to decide whether or not to allow the COX-2 inhibitors to remain on the market, and also to decide whether or not one of them that was removed from the market, Vioxx, should be allowed to return to the market. And they engaged 26 physicians to do the analysis of these drugs. The vote on Celebrex, one of the drugs, was 25 to 1. They pretty much agreed that even though there was an increased risk of cardiovascular events with Celebrex, that they would keep it on the market. The vote on the other two drugs, Vioxx and Bextra, was slightly in favor of keeping both of them on the market. I think the vote was something like 12 to 8. But if you dissected the vote out, This was reported in the New York Times. If you've dissected the vote out according to whether the individuals had a financial conflict of interest with the companies that made the drugs, there was a 9-to-1 vote in favor of keeping the drugs on the market for those who had a financial conflict of interest with the companies that made the drugs.
Yeah, yeah.
If those votes had been excluded, both of the drugs would have been rejected by this committee.
Yeah.
So what you have here is a group of doctors who have these financial conflicts of interest making judgments about the drugs that the company that is paying them to either give speeches or consult with them is making.
What was the situation with Celebrex in this regard?
Well, with Celebrex, the vote seemed to be pretty unanimous, so there was not any controversy about that.
Now, one point you make throughout the book, and I think it's probably relevant here, is that for all we know, the 9-to-1 who voted, who had conflicts of interest, and who voted in favor of putting Vioxx back on the market and the other drug back on the market, for all we know, that was their honest, good faith belief based on what they have seen in medicine. The problem is you don't know.
That's precisely the problem of conflict of interest. You put your finger on it as well as anybody has. That is that no matter whether you know the conflicts of interest of the individuals, they may be disclosed to you completely openly. The problem is you just don't know how to interpret it. So the question is, what do you do about that? Yeah. Well, my answer is, you should engage doctors in the evaluation of these drugs who do not have a financial conflict of interest. Or, sure, you could have some of them who do have conflicts, but they should be overwhelmed by people who have no axe to grind, no cross to bear. So my belief is that there ought to be ways of protecting the public against financial conflict of interest by engaging experts on analysis of data.
Yeah, yeah. It very much sounds to me very much like the increase in the use of outside directors after the Sarbanes-Oxley Act, as opposed to inside directors. Doctor, the federal agencies, I gather, and the medical establishment and the pharmaceutical companies say, look, the reason that we're going to have these conflicts of interest is that there are so many ties now between physicians and research physicians and the device and drug companies that it is not really possible these days to get competent, knowledgeable people to serve on these boards and to give advice to the pharmaceutical companies and so on, and to create medical practice guidelines, which we'll get. There's no way you can do this without having conflicts of interest, because the interlocks are so all-pervasive. What's your view of that?
Well, Larry, let me answer by saying that nobody has ever shown any evidence that people who are involved with the pharmaceutical industry are better at analyzing data than people who are not involved. So the first point is that can you find experts? Can you find experts in data analysis to do the analyses? The answer is yes.
Who are not involved. You're denying their fundamental point that it's impossible to find competent people. You say it is possible.
It is possible to find people. Having said that, what does it say about the fact that when you look for experts, it's hard to find them? What it says is that there's tremendous involvement of the medical establishment with industry. Is that a good thing? Well, to some extent, it might be a good thing. For example, I think that involvement of physicians in consultations with industry on scientific issues, on development of diagnostic tools and things like that, that's something we should promote. But we should not be promoting involvement of physicians in marketing issues. We should not be promoting involvement of physicians in educational ventures or developing educational materials. So what it says is that there's an overwhelming involvement of physicians with industry. And my belief is that involvement is excessive and problematic.
Yep. One last question before we go to break. I was just thunderstruck in reading your book to find out that apparently some of these doctors who are involved with industry publish articles promoting a particular drug, but they don't write the articles. The marketing departments of the pharmaceutical companies write the articles for them, and they simply put their names to the articles. Is this very, as I mentioned to you, the same thing has been going on now in the universities, including in the law schools and in science departments, I must say too, in universities, where professors have students write things for them and they put their names to what the students have written. Is this ghostwriting very common in the medical field?
You know, we have no idea how common ghostwriting is. We know it occurs. To me, it's a violation of integrity. However, it goes on. Most recently, there was an instance in which I found really quite astonishing. A couple of days ago in the New York Times, it was reported that a physician had signed his name to a study, not just an opinion piece, but an actual clinical trial, signed his name to it. This is a rheumatologist, I think, from Arizona, signed his name to a drug trial when he hadn't performed the trial, hadn't been involved in performing the trial at all. He did some editing, and that was it. Just signed his name. Now that seems to me extraordinary.
Yeah, yeah.
Why would people do that?
It's ghost research.
My guess is he probably did it because he was paid to do it.
Yeah, yeah. It goes beyond ghostwriting to ghost research. Oh man. We have to take another break. Stay with us. We will be right back with Dr. Jerome Kassirer after this break.
Integrity first. Service before self. Excellence in all we do. These are not just words. These are our core values. Values by which each and every member of the Air Force Reserve lives. So whether we are deploying humanitarian aid or providing natural disaster relief, or defending freedom wherever it's threatened, the men and women of the Air Force Reserve are there, protecting our values and serving our country. Air Force Reserve, above and beyond.
There is strength in our numbers. Our call is to action, to practice what we preach. Be there to care. Our passion is compassion. We're only human, but together we're humane. Our letters stand for taking a stand, for taking the lead, for filling the need. The American Society for Prevention of Cruelty to Animals. Be part of our heart.
Exercise your emotions. Attend a live orchestra concert. Go to findaconcert.com.
Welcome back. Doctor, do doctors ever give patients drugs or tests or even surgery that the patients don't really need and are being given because the doctor benefits financially from this?
Well, that would be a little stronger than I would be willing to describe it as. There is an incentive to prescribe tests if the doctor will benefit from the test. There is a tendency for a surgeon to recommend a specific kind of procedure that he or she themselves do rather than a different kind of procedure. Let me give you a specific example. A woman who goes to a doctor, a gynecologist, for a fibroid tumor, if she goes to a gynecologist, the gynecologist is probably going to recommend a surgical procedure, either removal of the uterus or removal of the tumor. If instead the woman goes to an internist and is referred to an interventional radiologist, they may, instead of recommending surgery, they may snake a tube, a catheter, into the artery that leads to the tumor, inject some little spheres, and try to kill the tumor, to shrink the tumor.
Yeah.
Now, why should the decision about the right procedure for a woman be determined by which doctor she goes to?
Yeah, yeah.
It should be determined by what's best for the woman.
Yeah, yeah.
But so that incentives do play a role. Now, it may be that both of the procedures are equally good, except that the woman who's operated on it is going to be, out of service out of commission for a few days.
You ever hear the expression that when you're a hammer, everything looks like a nail?
Well, that's sort of the same thing.
Yeah. We had some famous situations involving Resolin, Redux, and a young man named Gelsinger who died at the University of Pennsylvania Medical Center. Do you think that financial incentives in any way had any impact on the fact that people were given these medicines, or that Gelsinger was enrolled in this clinical test from which he died?
Well, that was the suspicion in every one of the instances that you mentioned. The concern was that in every one of those situations, which are described in much greater detail in the book, the concern was that financial conflict of interest had an effect on, in the case of an editorial that was written in the New England Journal, it may have biased the individuals in favor of recommending drug therapy. In the case of Resolin, may have biased a group at the FDA in favor of continuing the drug on the market, despite the fact that there were complications. And in the face of the Gelsinger boy, may have pushed the experiment a little too fast because of financial conflicts of interest. Whether or not these conflicts had any influence on that is something that is still conjecture.
You mentioned that a couple of things that seem to be related. Clinical trials have become, of course, a major way of determining whether drugs are good, bad, or indifferent. And the clinical trials are often, you point out, conducted not one drug versus another, but a drug versus a placebo, which makes a difference. And you talk a lot in these regards about evidence-based medicine and about designing about the big pharma designing the clinical trials in ways that ensure that a company's own products will not suffer in reputation. Why don't you elaborate on all of this? It all seems interrelated.
Well, the issue is how do you design a clinical trial to get the best possible information? Clearly, if you're looking at a new drug, what you'd like to be able to do is to compare that new drug to the best available treatment at the moment, not to placebo. A new drug is almost certainly going to operate better than placebo, but the question is it better than what we already have? Yeah. So the design of a study is critically important. in making judgments about what the results will be. The clinical trials and studies of all kind can be jiggered to produce the favorable results. And even once the study is finished, the kind of discussion in a scientific paper can be oriented in a favorable way. So editors of medical journals have to be careful about those kinds of things, and there's a move recently to try to get the drug companies to register these trials, to describe what these trials are ahead of time, and to make them a lot less susceptible to bias.
If there were a national registry of that nature, then drug companies would not be able to permanently, at least, maybe not even temporarily, suppress, as it were, the results of unfavorable clinical trials.
That's right.
Yeah, yeah. There's a moral issue involved here too, I gather, Doctor, which is particularly when people are very ill and need some kind of medicine, and we're trying a new drug on them. When you give somebody a placebo, I mean, the moral issue is, are you in effect condemning them to death because it won't do anything for them?
That's a subject that is far too complex to get into in a couple of minutes. There is a moral issue, but there's also a moral responsibility of science to find out whether one treatment is better than another. Yeah. And in some instances, you really must try a new agent against placebo. Yeah. Otherwise, you may be getting information that is worthless. So comparative studies of patients with some of them getting placebos, some of them not getting placebos, how else are we going to get that kind of information?
Not to pursue this overly long, but I just read the book about Jonas Salk. I guess there are two of them out now. I read one of the books about Jonas Salk's discovery, invention, call it what you will, of the Salk vaccine. And around 1954 and 5, when they tried a huge clinical trial, I think 2 million people were inoculated. They wanted to try, a placebo against the trial, but polio was so dreadful that they finally came down on the side and said, we're going to have to take the chance. They took a chance, incidentally, that 2 million people would come down with polio if this vaccine had the reverse effect from what they hoped. It all turned out well. But that was one example of the moral qualms that they faced. This time would be by not treating people. Doctor, you make the point that well, certainly I've read recently, whether it's you or others, make the point that a huge share of academic research is financed by the pharmaceutical companies, which I understand to have started, and please say if this is wrong, when Dr. Judah Folkman was having trouble raising money for cancer research. He was doing something which he's still doing, working on angiogenesis. And they got Monsanto to sponsor it to the tune of $23 million, and that was the beginning of pharmaceutical companies sponsoring medical research. Before that, the pharmaceutical companies weren't heavily involved in medical research, and there wasn't that much medical research. So the bottom line on what I'm asking you here is, if it had not been for pharmaceutical companies sponsoring medical research and for researchers obtaining the ability to create their own companies to profit from their research, and the universities profit from their research, do you think we would have had the kinds of, number one, is anything I've said wrong? Number two, if it's not wrong, or if much of it is right, would we have had the kind of progress that we have had? And what do you think about the future if Big Pharma no longer funds medical research?
Well, you've asked 15 questions.
I have indeed, and you have at least 3 minutes.
I think it's quite clear that the arrangement that the Massachusetts General Hospital made with Monsanto was a landmark decision, or a landmark pact that fundamentally changed the way medical research was being carried out. And part of that was based on the fact that subsequent to that, in 1980, Congress actually passed a law which promoted that kind of arrangement. There's no question that there has been important research that has come out of the connections of physicians with their own companies and with industry in general. Whether or not this is a positive thing overall or a negative thing is still to be looked at. There are some important negatives of these relationships, including the academic physicians paying less attention to the important work that they're supposed to be doing for the university. In research? In research, or the idea that instead of doing intellectually important research, they're doing pragmatic research and things like that, or whether they're working for themselves instead of working for the university. These are very complex issues. There's no doubt in my mind that some of this research has yielded very important new drugs, new devices. But I think the jury is still out.
Wouldn't the pragmatic research, I mean, this is a question, however I phrase it, maybe I phrase it like a declaratory sentence, but it's a question. Hasn't a lot of what you termed the pragmatic research been the kind of research which in industry is considered bringing abstract science into the actual marketplace by converting it into inventions and to practical products? Hasn't that been a lot of what's been involved in medicine in what you call the pragmatic research?
There's a major push now to take the scientific advances in the laboratory and move it into useful products, so-called translational research. Those efforts are ongoing. They're useful. They're important. And whether or not the arrangements that physicians make with industry will compromise them in some way is something that we have to worry about.
Yeah. I suppose one might also say that the foundational research, the basic scientific research, sometimes people describe it as just trying to find out why things happen without any concern for what you can do with it. But that has led to the most amazing pragmatic applications in future years.
It certainly has.
Yeah, yeah. Doctor, explain a little bit about what Big Pharma is promoting in terms of off-label uses. Explain what an off-label use is and what's been happening.
Well, when a drug is approved by the FDA for the use in any particular application, it can be used by a physician for any other application. That's what off-label use means.
Yeah.
Now, industry is not allowed to promote the use of off-label drugs. Their drug representatives, their detail men, are not allowed to offer information about off-label drugs. If they're asked by the doctor for information, they can give the information, but they're not allowed to promote it. The pharmaceutical companies are not allowed to advertise it unless it's been approved by the FDA. But doctors have no such restriction. So doctors can, if they're giving a lecture, they can promote the use of off-label drugs. There's no restriction on them. And the pharmaceutical companies are often paying doctors whom they know will promote the use of off-label drugs.
And sometimes this is dangerous, and sometimes it's not. Doctor, we have to wrap. I'm getting the high side, and people are jumping out of their skins. So thank you very much. Appreciate it very much. I think a most instructive experience for the audience. I'm sure people learned an awful lot from this. Medicine is something of a black hole for most of us, after all, which is unfortunate. But thank you very much for coming up here to be on our show. To the audience, be with us again next time for the next installment of Books of Our Time.